about to start our session, just cases in ocular oncology and pathology. So the other chairperson will be joining us shortly. So I will call on the podium Devansh Kansal. Is Devansh there? Yeah, so Devansh will be presenting a case on optic nerve infiltration in acute lymphoblastic leukemia, unraveling the visual impact. Over to you, Devansh.
Good morning, everybody. My topic of presentation is optic nerve infiltration in acute lymphoblastic leukemia, unraveling the visual impact. ALL is a malignant hematological disease presenting clinically with proliferation of immature lymphatic cells in the bone marrow and peripheral blood. Ocular symptoms can occur in different stages of ALL. They can be the first manifestation of leukemia, either primary or secondary. It can occur after diagnosis has been established or be the first sign of the relapse after remission. Secondary ocular manifestations include retinal hemorrhage and retinal venous occlusions due to hematological abnormalities. Intraocular involvement with infiltration of the optic nerve and associated optic swelling and fundus hemorrhages can occur. So a 16-year-old male patient, a known case of T-cell ALL, on treatment with augmented BFM protocol as chemotherapy. And 3 months after the chemotherapy was started, he complained of bilateral sudden loss of vision in both the eyes. And on ocular examination, the perception of light was negative in both the eyes, and the fundus examination revealed both eyes disc edema with pallor with peripapillary superficial hemorrhages, exudates with dot hemorrhages at the posterior pole. MRI of the brain and orbit revealed right intraorbital, left intraorbital, intracranial portions of optic nerve appear thickened, tortuous with post-contrast enhancement involving sheath, which is suggestive of leukemic infiltration of the optic nerve. So the diagnosis was made bilateral infiltrate optic neuropathy with right cilio-retinal artery occlusion, which is suggestive of relapse of T-cell acute lymphoblastic leukemia. So the treatment which was given was ALL protocol augmented BFM therapy, which includes induction phase, interim maintenance phase, and delayed intensification and maintenance phase. So our patient was on interim maintenance phase when he developed sudden bilateral loss of vision. An MRI of the brain and orbit and CSF study to look for leukemic cells can help guide urgent management of leukemic optic neuropathy. The management of L1 is multidisciplinary. Patient with L1 may require intrathecal chemotherapy and orbital radiation, and prompt oncology consultation is recommended for all the cases. Discussion: ocular findings in leukemia is due to leukemia and induced hyperviscosity status, medications used in treatment of leukemia, and immunosuppressive state. Choroid and retina are the most common site of involvement in leukemia. Optic nerve involvement could be a life-threatening sign. Disc edema in a leukemia patient could be due to direct infiltration of the optic disc leukemic cells, papillary edema due to increased intracranial tension, hydrocephalus caused by CNS leukemia. These are the causes which can cause disc edema in a leukemia patient. So conclusion is, this case highlights the clinical and imaging findings of bilateral optic nerve leukemic infiltration as a site of initial relapse of T-cell ALL. Disc edema in a case of leukemia is an indication for urgent CNS radiation treatment. As the survival rates after treatment, after therapy for leukemia are increasing and the quality of life parameters are becoming more important, the role of ophthalmologists in the holistic management of patients with this condition is also increasing. It underscores the significance of multidisciplinary collaboration between hematologists, oncologists, and the ophthalmologists in optimizing patients' outcomes. These are references.
Yeah, great case, Devansh. So if you can just summarize for the audience, what were the fundus findings you found in this patient? Because what I understand, this was not a known case of ALL.
This was a known case of ALL. For the past 3 months, he was on chemotherapy.
Okay, so what are the fundus findings that you see in these cases that will help us? It might be the case that they present with the ocular findings, no? So if you can just summarize what were the findings on fundus that you saw.
The fundus findings can be the fundus findings can be superficial hemorrhages, dot hemorrhages, rough spots can be seen, and disc edema can be seen, and ultimately the optic nerve can get involved.
Yeah. So how does the rod spot look like?
The rod spots is the hemorrhage with a central white spot in between.
Central. Okay, thank you, Devansh. So next I will call on the podium Sneha. Is Sneha there? Sneha is there. If not, next we move on to Dr. Vandana Iyer. Yeah, so Dr. Vandana will be presenting on chronic myeloid leukemia masquerading as vitreous hemorrhage in the eye.
I'm Dr. Vandana here from AIOCMT3 Nagpur. First of all, I would like to thank AIOS to give me this opportunity to present in front of you. This is an interesting case of a 23-year-old male who presented with sudden painless progressive diminution of vision in the right eye for past 5 days. This was preceded by a painless progressive loss of vision in the left eye. Onset was unnoticed, probably it was past 3 weeks. It was a chronic tobacco user for past 5 years. The negative history was unremarkable. On examination, right eye vision was 612, while left eye was PLPR inaccurate. Both eye pressures were normal. Right eye anterior segment examination was normal. Left eye revealed a RAPD and a reddish reflex behind the lens, behind a clear lens. On fundus examination, the right eye showed hyperemic edematous disc with dilated tortuous vessels on the posterior pole and scattered white-centered hemorrhages, also called rock spots, and free retinal hemorrhages all over the fundus. Left eye revealed a massive vitreous hemorrhage. A diagnosis of differentials was placed: right eye impending CRB of the young, coagulopathy related retinopathy, anemic or leukemic retinopathy, and left eye vitreous hemorrhage due to any of the above. On ocular investigation, right eye OCT revealed thickening of the retinal nerve fiber layer, no macular edema, while left eye revealed a massive vitreous hemorrhage on B-scan. The blood investigations further found that the patient was anemic grossly with an HB of 7.8 gram per deciliter. WBC count was more than 5 lakhs per microliter, and peripheral smear revealed neutrophilic leukocytosis with marked left shift and myelocyte bulge, which was suggestive of chronic myeloid leukemia. Empirical treatment was started on tablet hydroxyurea with febuxostat. Further investigation with RT-PCR revealed BCR-ABL mutation positive, that is Philadelphia chromosome positive. Definitive treatment was started on imatinib methylated tablet, and hydroxyurea was stopped. So we expected the patient to improve actually, but 2 days later we saw that the patient had worsened and the right eye was looking more aggressive with worsening of disc edema and rod spots. Left eye showed a spillover bleed from the posterior to the anterior chamber, causing total hyphema. The pressures were increased to 42 millimeters of mercury. The B-scan ultrasonography now showed a central clearing. This looked more like a total retinal detachment with subretinal deposits. Probably this could be hemorrhage or tumor infiltrate. So we actually discussed the case with a hemato-oncologist and an ocular oncologist. So several postulates for left eye worsening were placed. Either it was a direct invasion of tumor cells or indirectly thrombocytopenia, anemia, reduced platelet and bleeding tendency leading to the accumulation below the subretinal space. Pseudo von Willebrand factor deficiency associated with CML. Side effect of chemotherapy, that is imatinib mesylate, is known to have been associated with platelet dysfunction. Then blast transformation of CML to ALL. This ALL or even AML, this seemed to be the most plausible reason. So our ocular pathologist advised us to give intrathecal dexamethasone. But the patient's platelet count at that point in time was less than 50,000. So we had to start him on intravenous dexamethasone. So this is a fundus picture. The patient again improved in 2-3 days. The right eye drastically improved, the vision improved to 6/9, and the rod spots disappeared and the disc edema also reduced. Left eye, the intercalary cephaloma resolved. The pressures also decreased from 42 to 18 and the hyphema became organized. So CML is initially treated with hydroxyurea, is followed by imatinib mesylate when we have proven the diagnosis. If we find that there is any worsening after starting the chemotherapy, then we have to start the patient on intrathecal dexamethasone. If it is greater than 50,000 platelet count. If platelet count is less than 50,000, then we will start on intravenous dexamethasone. Newer modalities are also there in the form of injections of dexamethasone or intravitreal anti-VEGF or methotrexate. So this is my take-home message. CML masquerading in the eye is a rare occurrence. If it's not responding to routine treatment, it may be due to blast transformation. So it may need treatment modification and multidisciplinary approach may be needed. These are my references.
Definitely an interesting case, Vanna, because this is really a very rare occurrence. Generally, orbital manifestations are seen, but intraocular and that too mimicking these type of vitreous hemorrhage is rare.
Yes.
So a very well documented case, Vandana. Again, like when the patient initially presented to you with that right eye multiple hot spot, left eye vitreous hemorrhage, was he already a diagnosed case of CML?
No, ma'am. So he just presented as a vitreous hemorrhage, and right eye was absolutely normal. He's a normal male walking, young male walking into our OPD, and like drastically worsened after finding out that it is CML. We thought that he will improve, and it was contrary to our expectation.
Yeah, but that is very important, like to know these features. That's what we were discussing in the last case as well. To know this as a typical fundus finding of a patient with CML and going ahead with just a peripheral blood smear helps.
Yes, ma'am.
Thank you.
Thank you.
In these type of cases with vitreous hemorrhage, you would like to clear off the vitreous with vitrectomy or not? With these type of blood counts with the patient.
So if the reports if like as the reports it won't suggest like it's something else, then we can go ahead.
We can go to have a
Better,
under view
yeah,
and
better
all that
view,
stuff.
better
So,
view.
but
Because the pressures were so much that we were actually trying to lower them and then only wanting to intervene. And after this, the patient was lost to follow-up also, so we don't know what happened.
okay. Thank you.
Thank you.
So next we call Dr. Arnab Mandal. Arnab will be presenting on unaccepted outcomes after upper eyelid sebaceous gland carcinoma excision in an old male patient.
Good morning, everyone. Today I am going to present on unexpected outcome after upper eyelid sebaceous gland carcinoma excision in an old male patient. Sebaceous gland carcinoma is the third most common malignancy of the eyelid, and it usually occurs 5 to 9 decades of life. Women are more commonly affected than the men, and it mostly involves the upper eyelid, arises from meibomian gland of Zeiss and Moll. 70 years old male presented with left upper eyelid mass since 1 year, which was insidious in onset and gradually increasing in size. It was 9 into 10 into 6.5 mm in size, globular in shape, having irregular surface, firm in consistency, immobile, with yellowish coloration and telangiectatic vessels on surface, and it was located at the junction of middle 2/3 and lateral 1/3 of the upper eyelid. No palpable regional lymph node was found. The patient underwent Cutler-Beard surgery with excision of the entire mass with 5 mm clear margin, then advancement of the lower eyelid flap and secondary reconstruction of the eyelid. First skin marking done, traction sutures applied, skin incision done, and the entire mass with 5 mm clear margin was excised, and the marking of the lower eyelid advancement flap and incision done, and lower eyelid advancement flap was anastomosed with the upper eyelid. Unfortunately, on postoperative follow-up, patient didn't follow up properly. He came after 3 weeks of surgery, and we found that there was presence of sutures and elevated swelling of the flap, which looks similar to the preoperative picture. This is a preoperative appearance. This is the preoperative appearance of the tumor,
And this picture shows after 3 weeks of the surgery. There's presence of sutures and edematous swelling of the flap. Then I immediately removed the sutures and iodine massage was done. And the flap edema gradually disappeared over the period of time. This is day 20, this is day 27, and this is day 34 picture. This flap edema happened due to presence of sutures more than 3 weeks, which causes venous stasis and disruption of the drainage of the venous drainage and lymphatics. And histopathological report shows poorly differentiated nodular sebaceous gland carcinoma, and the depth of infiltration was 0.3 cm, and all surgical margins are away from the tumor, closest being 0.3 cm clear on the medial aspect. And this is 10 times, 40 times and 100 times magnification under microscope. After 6 weeks of first stage of cutler beer surgery, the patient underwent second stage of the surgery, and the incision done at the level of the eyelid margin, and the excised area is sutures with a lower eyelid. And this picture, last picture, shows after 2 weeks of the second stage of surgery and removal of the sutures. The patient was asymptomatic on 1 year postoperative follow-up. And my take-home message is regular follow-up after sebaceous gland carcinoma surgery is very, very important, and timely suture removal is needed to prevent such complications. Thank you.
I have a couple of things. One, sebaceous gland carcinoma is the most common lid tumor in our country. The thing which you said, it's the third most common. This is in Western literature, because their sebaceous gland is not on top of the list. I think melanoma, squamous cell carcinomas are on the list.
Distal cell carcinoma is the first, second is squamous cell, then according to literature. In our country, it is sebaceous gland carcinoma.
So when you're presenting in our country and the patient is of this country, this is the most common. Secondly, the edema of the flap is very common. It is not because of the sutures. Sutures don't cause edema, because the flow of the lymphatics or the blood is from the lower lid. The blood vessels are there in the pedicle of the flap. That is not obstructed by the sutures. Sutures are on the edges. So basically, suture is the graft-verse junction, sort of, right? So there it won't cause, and it is because of tight lower lid, that bridge which you create and from which you take out the flap. Initially there will be a surgical edema anyways, if the patient is not coming for a proper follow-up or if it's a tight bridge from which you have taken out the flap, right? Then there is a possibility of edema, which is quite common with these type of procedures. Removing the sutures or not removing the sutures is not very thing. Sometimes I don't remove all my sutures even till the second stage, right? In the edges and all. I use fractal sutures now. I don't use proline because those edges are quite sharp and they keep bothering the patient, because sometimes those sutures are the grafts are large. Sometimes they are within the bridge. They may be eroding those or touching those conjunctival edges. So I don't use proline all over. You use proline in this picture, I believe. So Vicryl is good enough.
So I use the Vicryl.
So Vicryl is good enough, and Vicryl, as we all know, are absorbable. They get loosened up after a couple of weeks anyways, right? So I feel that the takeaway, the message which you are trying to give, that removal of the sutures are important to avoid the edema. To my knowledge, it's not.
Yeah, completely agree to that what Dr. Raman said. Like the sutures, we also do it with Vicryl and it just falls off. So sutures are not much importance there, and it is basically the lymphedema which happens and which comes down with time, and it's pretty common. So I have two questions for you, Anup. So one is, how did you ensure margin clearance in this patient? Because whenever we are treating a malignant eyelid tumor, margin clearance is of utmost importance for ensuring that the tumor doesn't recur. So how did you do that for this particular patient?
Yes, madam. We send clinically we cleared the hyperlimited clear margin with intermass, and we send for histopathological examination. The histopathological report shows that all the margins are cleared, but we have no intraoperative pathological center for report for clearance of the margins. But we send the tumor after 2 weeks after 3 to 4 weeks when the report came, and it showed all the margins are clear, and the closest being the 0.3 centimeter. So from that point of view, we think and we follow up the patient for the next 1 year. And
yeah, that's fine, no. But what the point I'm trying to make here is you went ahead with the reconstruction on the same sitting, right?
no, after 6 weeks, we after 6 weeks, I go for the second stage of the surgery.
No, I'm talking about the eyelid sharing
Eyelid
procedure
sharing, yes,
that you did on the same sitting.
Same sitting.
So that is not the standard of care. So
Yes.
that's what I'm trying to make a point here. Either you have if you have a frozen section facility around, you send for frozen section and take it up on the same day, or you wait for the permanent section report to come up. So suppose in this, you said you got the permanent section report after 3 weeks. Suppose it comes as positive. What will you do now? You have already done a eyelid sharing procedure. In 3 weeks, it's everything is like it is taken up. Like it has. What will you do now? Like unnecessarily, you will be subjecting the patient to radiotherapy and all. So the morbidity increases.
Yes.
So margin clearance is something you need to consider for all these patients.
Agree with Anusuya, but the only thing practical problem Anusuya is frozen section is not available easily. Like even inner cities like what I am practicing in Amritsar, Chandigarh also, there is only one place doing frozen section. That is into a corporate. They generally don't take your frozen sections when you are practicing from out. So that's practically impractical for doing frozen section in most of these type of scenarios. If we take a good margin clearance from the clinically suspected tumors, then like I keep doing the way he's done from primary one. And in case, as you say, if you land up into a problem where you have that margin is positive, then when you're going in for a second stage, then probably you would do a second stage surgery, and I would also excise that junction, making like a pentagon excision we would have done, because that will be the only margin, and resubject it for histopathology as a new border. So that is probably what we can do, as if what you say. But fortunately, I have been lucky. Maybe in my 20 years of practice, once we have done those excisions, I have never come across a positive margin.
What about permanent section? They take so much time. He's saying 3 weeks is what it
2 weeks is generally they take. Actually, when they make different slides, 10 to 15 days is. You can ask them to give a early report, but minimum 10-12 days they take. Thanks, Arnav. That was a good case. Can we have the next speaker?
Navdeep Kaur. Navdeep is not there. We will have Renu then. Renu will be presenting on pigmented basal cell carcinoma, a rare case report.
और नीचे कर दो माइक ऑन था पहले अब आपने बंद कर दिया
Good morning everyone. Today I am going to present a rare case report of pigmented basal cell carcinoma. So starting with the introduction, basal cell carcinoma is a skin malignancy that arises from the basal cells of the lower layers of the epidermis. It accounts for approximately 90% of the eyelid malignancies, with lower lid being the most common site. The pigmented basal cell carcinoma is a rare subtype of the basal cell carcinoma, and it only accounts for 6 to 10% of the cases. Pigmented basal cell carcinoma is characterized by the presence of melanin pigment within tumor, which gives it a distinctive appearance. So the case report is a 72-year female which presented with a chief complaint of a nodule on the left lower eyelid for almost 12 months, which is gradually increasing in size and slowly become blackish and ulcerated. The patient also complained of watering and foreign body sensations in the left eye without any history of any bleeding or discharge from the lesion. There is a history of topical antibiotic and lubricant eye drop use for almost 8 months. The examination shows all within normal limits except that a left eye lower lid with a mass of size 1.7 into 1.2 centimeter blackish ulcerated nodule. The CT and the MRI of left orbit shows no signs of local invasion, and the routine complete blood count was within normal limit with a hemoglobin of 10.2 gram per deciliter and total leukocyte count being 8000 per centimeter cube and platelet count of 1.90 lakhs per mm cube. The white local excision of the lesion along with the tensile semicircular rotational flap reconstruction was done, and the histopathological examination shows pigmented basal cell carcinomas with the free margins. This is the image, the pre-operative image and the post-operative image on day 1 after lid reconstruction, and the histopathological examination shows the presence of melanin pigment with around the tumor cells, confirming the appearance of pigmented basal cell carcinoma. So the discussion is pigmented basal cell carcinoma mimics melanoma, emphasizing the importance of biopsy for definitive diagnosis. The multidisciplinary collaboration between dermatology, ophthalmology and plastic surgery ensures comprehensive patient care. Old age and chronic sun exposure being the most important risk factor in this case. The pigmented basal cell carcinoma of the eyelid being slow growing yet locally invasive tendency necessitates the prompt diagnosis along with the proper surgical interventions to establish the lid function in cosmesis. The histopathological examination revealed the tumor-free margins, which shows complete excision of the tumor, and follow-up at post-operative day 1, and day 7 shows healthy suture lines, and at day 21 shows excellent skin approximation. Thank you.
Thank you. Any comments or questions from the audience? It was a clear-cut and straightforward case, so I think not many discussions are required and very well done case. Tensils or otherwise the lid shearing procedure could be another way of reconstructing, because that larger lesion with about 4 to 5 millimeter on the side, practically you would take off the whole lid. Thank you. The next is Rajneel Bhattacharya. No. Ragam Chaitanya Lahiri. Mystery in the muscle. Okay. Vicky Agarwal. And Ruju is also there. So we have four next. So let's be very particular with the time.
Good morning all. I am here to present a case, mystery in the muscle, unveiling a rare case of orbital myxoma. 42-year-old female presented with a forward and outward deviation in the left eye since 2 years with restricted eyeball movements. Insidious onset gradually progressing, associated with redness, watering, headache since 2 months. There are no aggravating and relieving factors, no diurnal variations and not associated with pain. There is no history of any previous ocular or facial trauma. It is known hypertensive since 2 months on regular medications and no other systemic comorbidities, no history of previous ocular surgeries. Earlier diagnosed with a pseudotumor of the left eye, left orbit and treated with the oral prednisolone and methotrexate by her local ophthalmologist for a period of 8 months. There is no significant personal history, general examination well built and nourished, systemic examinations normal findings. Coming to ocular examination, on inspection no compensatory head posture seen, facial symmetry is maintained, ocular symmetry is lost, no visible pulsations or engorged wings, lid retraction is present, lid lag is present and lag of almost of 2 mm is present. There is inferior scleral show and there is no change in proptosis on Valsalva. Coming to anterior segment examination, right eye vision 6/60 with minus 4.50 diopters improving to 6/12 and normal anterior segment findings in the right eye with the normal color and pattern of the iris and normal, round regular reacting pupil with nuclear sclerosis of grade 1 to 2. Fundus is within normal limits with normal intraocular pressure. Coming to left eye, vision is 6 by 60 with -5 diopters, improving to 6 by 36. There is 2 mm of lag of tumors, misdirected and sticky eyelashes. Intern and straighten of the lid margins is seen. Conjunctiva is congested with chemosis. In the cornea, there are superficial punctate keratitis and it is FS positive. Normal anterior chamber depth with the normal color of iris and pattern, round regular reacting pupil with NS grade 2 and posterior subcapsular opacity with fundus normal intraocular pressure. Coming to palpebral fissure height in the right eye is 10 mm, MRT1 5 mm, MRT2 5 mm, HCRT is central and Schimmer's test is 35 millimeters of HD. Coming to the left eye, PFH is 13 mm, MRT1 is 5 mm, MRT2 is 8 mm, and there is 20 degrees of exotropia with vertical displacement of 3 mm and horizontal displacement of 12 mm. And these are the extraocular movements where there is a restriction in the right eye, dextro elevation, dextro depression and non adduction. And this is depicting the same. There is a restriction of movements of the left eye in adduction. On palpation and firm mass with periorbital fullness medially causing bulge in conjunctiva and carbuncle is seen. There is no local rise in temperature, no tenderness of crepitus, no pulsations, no bone irregularities, and on left eye force reduction test it is negative. On auscultation, no audible bruit is seen. And this is the CT section, axial and coronal sections of the CT showing heterogeneous mass noted in the medial rectus muscle with proptosis and exodeviation of the left eye. And MRI showing the hyperintense lesions in the extracoronal compartment of the left orbit in the medial aspect causing displacement of the globe outwards and laterally. You can see a fusiform enlargement of the mass in the medial rectus in the third and fourth and fifth photographs. And a provisional diagnosis of left orbit space occupying lesion involving the medial rectus muscle is made. On investigations, left eye B scan, there is normal findings and thyroid function tests are normal. An incisional biopsy with subconjunctival orbitotomy came out to be a HP report of myofibroblast spindle cell proliferation within loosely arranged myxoid stroma showing spindle stellate cells. Inflammatory cell infiltrate consisting of lymphocytes are also seen, possibly or suggestive of a myxoma. The management primary modality is surgical excision of the myxoma, but patient deemed the surgical excision, so next best modality of the treatment is radiation therapy. An intensity modulated radiotherapy as adaptive therapy given to the patient with a dose of 44 grams in 22 fractions over a period of 8 weeks. And this is a pre-radiotherapy photo, and after radiotherapy the patient has improved partially but not completely. And based on the CT findings done 1 year ago, the measurement of 3.7 into 2 into 2.1 centimeter has come down now to 1.7 into 3.6 centimeters. So these are my differential diagnosis of a space occupying benign lesions. And on discussion, before confirming a diagnosis of myxoma, any myxomatous tumor should have a thorough histological examination and imaging to know the extent and spread of the tumor. So far, only few cases of myxoma of the orbit have been reported. Intramuscular orbital myxomas are exceedingly rare entities. Although they are considerably benign, myxoma demonstrate high recurrence rates. This report a unique case of an orbital myxoma involving medial rectus with partial response to radiotherapy. And these are my case reports and references. Thank you.
I guess it will be really difficult to excise a tumor which is within the muscle belly, because in that case you'll be subjecting the muscle to total excision and the eye will go into exo. Secondly, your radiotherapy findings after the radiological findings, it was like 1.7 into 3.6, which it was hardly, the dimensions were changed. They wrote first 1.7 then 3.6 rather than 3.7 first. So there was hardly change in the dimensions of the tumor. Anyways, thank you. Can we have the next speaker?
Yeah, and
one more comment Dr. Anusuya wants to say.
Lahari. Yeah. Lahari. So nicely managed case. Why did you say it is partial response? So with radiotherapy, it is not always they shrink. What we look at is that there shouldn't be any progress from there. So you need to look into, and when you did, you talked about this incision biopsy. Was it an attempt to debulk
No,
the tumor?
just for HPD, like just to know the histological
Okay, so
Diagnostic biopsy.
yeah, myxomas are locally infiltrative, but the problem with them is recurrence. So
Yes,
we
ma'am.
need to follow up the patient closely.
Yes, ma'am.
Thank
So
you.
what probably Dr. Anushya wants to say is, in that case, when you can't excise, when your radiations are not giving you good response, at least you could debulk the tumor nicely, so that at least the patient would have a lesser proptosis and orbital stuffiness.
Yes.
Next speaker, please.
Good morning, everyone. Good morning, everyone. Today I am here to discuss a case of an unusual presentation of orbital lymphoma in a 3-year-old child. So, my patient, 3-year-old female, presented with chief complaints of protrusion of left eyeball for 2 months with irritability and decreased appetite, as informed by the mother. This is the photo taken at the time of presentation. Parents noticed protrusion of left eyeball 2 months back, which was gradually progressive, associated with pain, redness, loss of vision, intermittent bleeding from left eye, and was not associated with pus point or pus discharge. There was no similar episode in the past. There is no history of similar episode or any hereditary illness that runs in the family. She is born out of non-consanguineous marriage with uneventful perinatal period. So 1 month before presenting to our OPD, she underwent incisional biopsy of left eye outside, whose results were inconclusive, after which she was provisionally diagnosed as left eye rhabdomyosarcoma there. On general examination, patient was conscious but irritable, febrile. Systemic examination was normal. So on ocular examination of right eye, it was normal. On examination of left eye, she had proptosis with frozen globe, erythematous and tender eyelids. There was conjunctival congestion with a small incision scar over superotemporal quadrant from previous incisional biopsy. There was intermittent bleeding, and corneal opacity due to exposure keratitis was seen, as a result of which pupil and posterior segment could not be visualized. B scan could not be performed as the child was very irritable. So CCT done 1 month back showed heterogeneously enhancing extracorneal mass involving left orbit, infiltrating medial and lateral recti muscles. On the right is the T1 weighted CMRI brain and orbit image done after admission. Large well-defined hyperintense lesion involving intracorneal and extracorneal compartments of left orbit involving left optic nerve was seen. So few differentials that can be drawn from this case are rhabdomyosarcoma, orbital cellulitis, orbital retinoblastoma, neuroblastoma, orbital lymphoma, leukemia, and metastasis. So the patient was planned for incisional biopsy under general anesthesia, and metastasis workup was done. Under general anesthesia, all the bleeding vessels were cauterized and superior orbitotomy with incisional biopsy was done. Grossly, the sample appeared tan, whitish, shiny, and was soft on touch, and it was sent for histopathological examination. On histopathological examination, impression of high-grade B-cell non-Hodgkin lymphoma was made. Patient was referred to medical oncologist, and following metastatic workup was done. CSF cytology and bone marrow aspiration showed no evidence of metastasis. Left cervical lymphadenopathy was seen on CECT, and bicytopenia was also seen. So final diagnosis of stage 4 lymphoblastic lymphoma with c-MYC expression with CNS involvement was made. She was started on chemotherapy with injection vincristine, daunorubicin and asparginase, and intrathecal methotrexate for CNS involvement was given. This is the picture 2 weeks post surgical biopsy and following 1 cycle of chemotherapy. So the proptosis started reducing within 1 week of chemotherapy, and exposure keratopathy improved after 1 month of conservative management. Guarded vision prognosis was explained to the parents. She is in regular follow-up for last 7 months. So what are the take-home points? Orbital lymphoma in pediatric population is rare and can be misdiagnosed. Immediate intervention is necessary for early diagnosis. Any delay can cause upstaging of the disease. Biopsy from correct site is very important for proper determination of disease entity. So to conclude, a simple procedure like surgical biopsy when done correctly and on right time can change the course of treatment of disease and thus the life of patient. Thank you. These are my references. Thank you everyone.
Sure.
IHC was proven and it was LCA, CD19, 20 positive and CMYC expression was in 95% of the cells and the MIB labeling index was 95 to 98%.
Good. Which institute are you from?
AIIMS Bhubaneswar.
What was the histopathology subtype of the lymphoma?
Histopathology subtype of lymphoma was ma'am, it was alveolar type.
Alveolar type is a type of RMS.
Oh no ma'am, sorry.
So that's what
Subtype was actually ma'am, it was not mentioned.
it must be. Like we'll go back and see. It must be one of the aggressive subtypes like DLGCL. So the subtype didn't come out in your presentation. With the
Subtype was ma'am, it was not present there.
yeah, go back and
Yes,
ask the pathologist. Okay, thank you.
Thank you.
So we call.
If you cross check these things, na, then it's a nice case to be reported. I think you should plan to write it up.
Ocular surface squamous neoplasia (OSSN). Ocular surface squamous neoplasia encompasses various dysplastic changes affecting conjunctiva, cornea and the limbus. It is a prevalent malignancy affecting conjunctiva globally and highest incidence observed in the tropical regions. It was first documented by von Graffe in 1860. The grading system was introduced by Lee and Hurst and it is divided into three types: benign dysplasia, pre-invasive OSSN and invasive OSSN, and these are the subtypes which are mentioned. And histopathology remains the gold standard for the diagnosis. And for surgery, no-touch technique introduced by Sealed et al. Is preferred for surgical removal. This technique aims to remove the tumor with clear margin while minimizing the risk of microscopic seeding. Despite this, there is no consensus on optimal margin during the surgery. Coming to case 1, this is a case series of 4 different type of the cases. Coming to case 1, it is a case of 70-year-old female with mass encroaching right eye since 1 year, and on examination there is a papilliform type of the conjunctival lesion which involved around 9 o'clock hours, and visual acuity was quite good. On impression cytology, there is mild to moderate dysplasia as shown in the picture and highlighted, and this is the post-op picture after the surgery, post-op 1 month picture after the surgery. Pre-operative and post-operative mitomycin cycles were given. Coming to case 2, it is a case of 60-year-old female with redness and mass encroaching in the cornea right eye since 6 months. On slit lamp examination, it appeared as gelatinous type of carcinomatous lesion, and visual acuity is quite good in this case also. And this is the photomicrograph, histopathological photograph of the tumor showing the involvement of full thickness of epithelium, but there is no invasion. And this is the photograph of the patient after having surgery, 1 week post-op photograph. And excision of the mass is done, and it is followed by pre-operative and post-operative cycle was given, 3 post-operative cycles. Coming to case 3, it is a case of 40-year-old male presented with a pterygium-like mass in the left eye since 6 months. Visual acuity was good, and on impression cytology, we saw these cells in the dysplastic, which shows dysplastic changes. The patient was directly taken for the surgery without pre-operative cycle of mitomycin C. Mass excision was performed and post-operative patient commenced for 4 cycle of topical mitomycin C 0.04% along with mild steroid. Coming to case 4, it is a case of 45-year-old female with a mass in left thigh since 5 months. On slit lamp examination, it appears like leukoplakic type of carcinomatous lesion with melanocytic changes. On histopathology, it reveals the severe dysplasia with dysplasia of the squamous cell. The patient was reduced for excision of the mass along with pre and post-operative course of mitomycin C 0.04%, and we also do the cryotherapy along with the mass excision in this case. Coming to discussion, in our case series, the patients were taken between 40 to 70 years. Female predominance was seen, as female also go for outdoor area work and exposed for UVB rays. There is strong association of OSSN with human papilloma virus and HIV, but in this case no patient had HPV and HIV infection. Visual acuity was quite good in all 4 cases as supported by the literature. The lesion was located in interpalpebral area, which was also supported by the literature. Lesions have been described in varying appearance like morphology. There is gelatinous lesion, papilloform lesion and the leukoplakic lesions. Varying degree of dysplasia also seen, but normal polarity and basal layers of cells are often unremarkable. Pre-invasive OSSN have been classified as mild, moderate and severe based on the degree of involvement of the dysplastic epithelium and the layers affected. Treatment of ocular surface squamous neoplasia varies upon the lesion size and severity. Smaller lesion needs less invasive treatment like with complete excision with topical chemotherapy, while the larger invasive lesion also requires cryotherapy and radiotherapy sometimes. During surgery or margin beyond the visible area of disease, usually excise and cryotherapy can be used to freeze the remaining cancer cells. Mitomycin C, we give the mitomycin C in all of our 4
Kindly
patients.
wind up your case.
Yes. These are the pre-op and post-op pictures of all 4 cases. These are my references. Thank you.
Thank you. On alpha 2B. Mitomycin has become the next choice.
Not available
Yeah, that's the problem. And secondly, for larger lesions, you would first do chemotherapy, try to do a chemo reduction. That's the protocol. And if it is of the excisable state, then you straight away go in for excision. And cryotherapy should be done in all the
Yes,
cases
sir,
for the
all
HS.
cases.
You said only for the last case it was done.
Yes, sir. We done for all the cases. Yeah.
Okay.
For pterygium case, we do not.
Right. Thank you.
The other
Next
important
speaker.
thing there, whether next presenter please.
You please get ready with the
Yeah,
presentation.
get ready. So Shubha will be presenting a rare presentation of choriostoma as a caruncular mass.
Are the presentations of other speakers loaded? Better to load, na? Otherwise
Next one is also use overlap.
Is it right on his laptop? So if you have on the pen drive, you can use his laptop. Even on his laptop, it won't.
All of you can visualize this pink looking or a reddish stone on your screen. Can anybody take a guess as to what this can be? We agree, or we might all have a mental consensus at least to say that this is kind of a precious stone. This is actually a red carbuncle. However, when we have an eye for such a precious stone, why don't we have an eye for this? Why don't we look at what is pink in our OPD clinics? And what if the pink is the new gold, or the new platinum, or the new diamond? What we often know from the literature is that caruncular lesions are extremely rare, with about 0.3 to 1.1% of the total surface lesions, with majority of them being benign, and most of the series report that nevus from a caruncle is the most common lesion. and because of its rarity in presentation, it is difficult to diagnose and treat. So today we look at one such less frequent case in our OPD which walks in, and this is titled the carcinoma. We have a 32-year-old young lady who presented to us with a lesion at the inner angle of the eye or the middle canthus, which was there since the last 22 years but bothered her to come to us since the last 1 year, since it was painless and progressive. What we do best at our clinics is have a focused case-based approach and have a detailed eye for a slit lamp evaluation, which shows in this case a fleshy pink non-pigmented mass of the dimensions as mentioned, with the posterior border not so discernible, which is not tender, soft to firm in consistency with no fixicity to the sclera and no prominence on Q-tip pressure. However, what is interesting to note is that there is a yellowish hue inferiorly, if you may see and appreciate, and there are cilia through the lesion, giving it a hint, and with no other puncture not being involved, ruling out possible lacrimal involvement. And our differential diagnosis in this case were a choristoma or a sebaceous gland neoplasm or a papilloma. So what best is provisional diagnosis or the working diagnosis definitely helps in having a mental workup before you go and take the patient on surgery. However, what's most important is the definitive diagnosis, which is always on histopathology. So what best is to put the lumbricals of the expert to work, and the operating surgeon is Dr. Fanavar here, where we went ahead with a complete excision of the mass using a monopolar radiofrequency electrode, followed by a pedicle excision of the same mass using a bipolar electrode to minimize the bleeding associated with it, and later reconstructing the surface with glue. And on subsequent histopathological examination, what you might appreciate on the screen on the left hand side is a gross specimen photograph showing a fibrofatty tissue with a keratinized skin surface and cilia projecting through the surface of the lesion, and on the right hand side is the photomicrograph which shows presence of keratin pearls and other elements, and also glandular tissue, making us realize that it is two different histological subtypes that we see on this photomicrograph. And moving on to what this can be, let us just employ the 5 men which we know to learn new things in our OPD. What is it? It is a presence of a normal tissue at an abnormal location, and who constitute as a family to this lesion would be two different tissue types, making it a complex choristoma. If there was a single tissue type, it would have been a simple choristoma. Why is it important is, one, we look at the systemic associations with it, that is nevus sebaceous, Goldenhar syndrome, Klippel-Feil syndrome, and the encephalocranial involvement. And what has been always spoken about is the classification of these lesions and the presence of these on the epibulbar surface. However, what has been really rare is the involvement of the caruncle, with one such being reported in a 3-year-old girl, and we report such a case in a 34-year-old female. What is important that we have an eye and attention to detail on a slit lamp, a complete excision followed by histopathological confirmation, and then a window to the systemic examination where and when necessary. Thank you.
Thank you, Shubham. This simply suggests that even simple looking lesions could be taken into a deep dive, and you may have surprises. Right? Thank you. Can we have next speaker if we don't want to discuss it further? And please be ready. Do you want to have some comment or something?
Yeah, Shubha, how do you ensure that this is not going into the medial rectus or the medial orbit? So clinically, if you can just give the pointers.
Ocular motility limitation was not there on an examination. Second is, when we put a positive pressure on the globe, the prominence of that indicates that possibly it is not invading the orbit. So both of them are clinical pointers to what is there.
Correct. So if any of these were there, you would have gone ahead and done an orbital imaging. Yeah. Thank you, Shubha.
So good morning. Today I'll be presenting a case which I felt was quite interesting to me because the patient presented with something which initially we could not understand, but later we found that it was an intraocular as well as extraocular part of the tumor. He was a 51-year-old male when presented with diminished visual acuity for 6 months and a bit of swelling in the left eye for about a month. By local consultation, he was diagnosed as a case of diffuse choroidal hemangioma with secondary glaucoma and was started on timolol combination Dorzox T and other eye drops. He was also non-hypertensive for 5 years with erratic treatment compliance. No other significant systemic complaints were there. MRI T1, T2 waited and ultrasonography was done at the local images. So I'll start with the examination first. There was a bit of fullness in the left periocular area. Now dew-like lesion in the inferior lateral area of the left lobe was there. The right eye was within normal limits. His best corrected visual acuity and other things was all fine in the right eye. The left eye had dropped visual acuity to 624 and there was RAPD was positive with early PSC changes. On fundus examination, right was within normal limits, whereas the left showed a diffuse choroidal thickening and folds with pigment dispersion at places. Initially, we thought that we are dealing with something which is intraocular, but when we got the ultrasonography done, apart from the intraocular lesion, we could see here there was an extraocular extent which was just next to the optic nerve here, which raised suspicion to us and which had our ears on that we are dealing with something extra than something in the choroid. So the fluorescein angiography was done, which shows early hypofluorescence followed by the late hyperfluorescence into the choroidal areas of the left eye. You can see this in the collage. The OCT also revealed the right eye was normal, the left eye revealed that there was an elevated choroid and there was a mass lesion below the choroidal stuff. So we were dealing with a choroidal lesion. Now the MRI suggested there was a hypointense on T1 and hyperintense in T2. There was also an extraocular lesion with lateral rectus thickening. You see this, there is an extraocular lesion just next to the optic nerve there, and also there is thickening of the lateral rectus muscle. So that was something confusing because we were thinking what are we dealing with. There were few diagnoses because of the pigmentation. We also kept melanoma there in our brains, ocular lymphomas, choroidal hemangiomas, choroidal secondaries, posterior scleritis and whatnot. Choroidal melanoma with orbital extension was our working diagnosis when we proceeded with it. The history was revised, but there was no history of sudden or rapid weight gain or loss, associated pain, tuberculosis or similar complaints in the past. No pigmented lesion in any part of the body. Investigation requested were chest X-ray, ultrasound abdomen and CT scan abdomen to rule out any systemic pathology. Maybe we are dealing with something secondary is in the first go. Everything was within normal limits. So what next? We thought of taking a histopathological diagnosis on the basis of incisional biopsy. So I conducted the incisional biopsy through the conjunctival approach and explored the retrobulbar area, and the pigmented lesion which was seen was biopsied. It was sent separately for histopathology. The lateral rectus and the orbital mass was sent separately. It came out to be a lymphoproliferative lesion of the orbit, suspicious of low-grade non-Hodgkin's lymphoma of the left eye. And IHC was done for confirmation. It was diffuse strong staining with CD20 and BCL2 and most lymphoid cells with CD3 staining, a few dispersed lymphocytes. So now we were sure that we are dealing with NHL and low-grade B-cell lymphoma favoring extranodal marginal zone or mild type of lymphoma. So the follow-up was done on 3 weeks. There was a bit of increased choroidal thickening with inferior exudative RD, probably because of the intervention we did. This is the ultrasonography. So we ruled out any systemic involvement again. The bone marrow biopsy was done, which was within normal limits. The patient was sent for radiotherapy on the basis of a histopathology report. After 2 cycles of EBRT, his choroidal thickening started decreasing. Follow-up slides show this collage, which was better. His improved vision was 624 No exudative RD was seen on fundus examination in the left eye thereafter. OCT also showed that the choroidal lesion has subsided. So a well diagnosed case, you can dwell with the patient, and a nicely conducted radiotherapy came to the salvage of the patient. The vision dropped because of the radiation induced cataract, which was later done, and the patient was post-operative 6 parts with a mild radiation keratopathy. The patient has now, after 3 years, his vision was still 6 part with all the investigations within normal limits, and patient has now completed around 15 years with me after post-operative findings. He is absolutely fine. I will skip the discussion with the sake of the timing. Thank you very much.
Thank you, Dr. Mitchell. That was fantastic. It's like for choroidal lymphomas, we rarely see such a presentation, and the B scan was so nicely showing the extrascleral involvement. And so I'm assuming at that time the systemic workup was also negative. So
Yes,
EBRD was the choice of
Yes, it
treatment.
was negative. It was negative all over.
Okay.
Even thereafter also we repeated the systemic investigation. That was again negative.
Yeah.
Thank you.
Treated with ruthenium 106 plaque. A 12-year-old boy presented to us with a pinkish discoloration of left hemiface since birth, and he had congestion in his eyes since about 1 week to 10 days. He did not have any underlying CNS manifestations. On examination, left hemiface had nevus clematis, and the visual acuity was perception of light with a 3-dioptric hyperopic shift on refraction. There was a tuft of dilated capillaries on the conjunctiva, episclera and sclera, and he had raised intraocular pressure. The montage view of the left eye showed a diffuse choroidal thickening with a large pinkish orange nodular mass in the inferior paramacular area associated with the subretinal detachment. The posterior fundus picture showed a nodular component with the height of it being less than 20% of the base of the choroidal hemangioma. An axial B scan showed a large dome-shaped elevation with internal echoes similar to the adjacent choroid. A maximum height of 5.68 mm was measured at 4 o'clock hours. With a backdrop of a patient with nevus flammeus, the funduscopy showing diffuse choroidal hemangioma, we diagnosed him to be a case of Sturge-Weber syndrome with secondary glaucoma. A screening MRI ruled out leptomeningeal angiomatosis. We had an array of treatment options. Observation was ruled out as visual loss was secondary to a treatable cause. Laser photocoagulation would have been visually morbid, and thus it was not done because it was in a critical area. External beam radiation was a possibility, however the irreversible functional loss associated with it. Plaque brachytherapy was thus the most feasible and safe option. He was treated with a ruthenium plaque at a dose rate of 4000 centigrade with a prophylactic injection of ranibizumab given at every 3 months. This is a serial fundus image showing excellent outcome at the baseline 3 months and 6 months with a very good visual improvement of perception of light to 6/9 by the end of the vision. So at the end of the treatment, he had a complete resorption of the subretinal fluid, stable regression of the nodular component, no radiation retinopathy, and a prolific improvement in the vision of 6/9 by around 18 months with complete resorption of subretinal fluid on the OCT as well. Encephalotrigeminal angiomatosis was first described in 1860 by Tumors and later on contributions by William Allen Sturger and Frederick Spark Weber in 1876. Interestingly, the first case that was described was actually a bilateral nevus flammeus with raised intraocular pressure. This is a phacomatosis with mutation of the GNAQ gene, and patients may have underlying CNS manifestations like leptomeningeal vascular malformation. The Anderson's rule states that if the upper lip is involved with vascular malformations, there is a very high degree of chance that an intraocular involvement is present. At many centers, external beam radiation is preferred as, however, the exposure of the healthy tissue to the radiation and the slow absorption of subretinal fluid may cause an irreversible functional loss. Diffuse choroidal hemangioma is an extensive choroidal mass. Often it is larger than the plaque designs that can accommodate.
However, we found that when the plaque brachytherapy is given to the thickest portion, it was sufficient enough to give an advantage of giving a precise, safe and reliable option to provide excellent results in controlling these patients. A review of literature was done and supportive evidence was shown by various other plaques as well to show stable regression of the nodular mass and complete resorption of the subretinal fluid. Diffuse choroidal hemangioma can be visually disabling. Imagine looking at the room with perception of light. Can you even see something? That's the end point of this treatment is a complete resorption of the subretinal fluid, and plaque brachytherapy is an excellent option for this. Thank you.
Thanks for completing it in time. Can we have the next speaker? We'll avoid discussion because our next session is to go. Next speaker, Rinki, please.
My name is Dr. Rinki Agarwal. Today I will present a case of unexpected diagnostic choroidal mass which gave us a sigh of relief. Okay, so the 44-year-old female presented to us with diminution of vision in right eye for 2 years and it was worsening since 1 year. First of all, she did not have any other significant history or systemically she was absolutely fine. On ocular findings, she noted dilated blood vessels or intratemporal iris with pigmented mass involving ciliary body, causing an anterior iris bulge. She also had irregular pupil and NS2 with reduced PSC. Infratemporal lens coloboma was noted. Her vision was 1/60 while other eye was absolutely normal. So you can see over here, there was a mass lesion noted in the inferior temporal quadrant and it had some dilated blood vessels along with causing pushing effect on the lens, that is lens coloboma inferiorly. So we made a diagnosis, provisional diagnosis of pigmented ciliary body tumor, choroidal melanoma, and then we performed a B-scan USG where we could appreciate a solid mass lesion with medium internal reflectivity in the anterior course of fiber, which was extending till distal lens, measuring 11 into 8.4 millimeters. Then even color Doppler appreciated there is central and peripheral vascularity within the tumor mass. MRI also on MRI we could appreciate the hypointense lesion on T2 and isointense to hyperintense on T1. It was quite limited. There was no encroachment on the ciliary on the other tissues of the eyeball or surrounding structures. Whole body PET scan was done because we were suspecting choroidal melanoma. It showed only the FDG uptake in the lesion with no other metastasis. So we made a diagnosis of ciliary body melanoma, and as the tumor mass was more than 0.8 cm³ with low visual acuity, we recommended radical surgical therapy, that is enucleation along with histopathological examination. So after enucleation, after we saw the result, it showed a tumor in the ciliary body and it showed bundles of fusiform slender spindle-shaped cells with the cytoplasm which was suggestive of leiomyoma rather than a choroidal melanoma. So pigmented ciliary body tumors can be multiple, they can be malignant or benign, and malignant as most commonly ciliary body melanoma is there. While in benign you have multiple other ones, in that post-traumatic iris cyst and leiomyomas are quite rare. So we can see that leiomyomas and melanomas almost, even though we describe array of differences between them clinically as well as on USG or MRI or PET scan, they are clinically impossible to differentiate these tumors, and that's why the very first approach towards these tumors, which if they are large, is enucleation. Other treatment tumor modalities like localized excisions, partial thickness scleral flap creation, and then excising the tumor, sending it for diagnostic biopsy, and then taking a step if it is positive. They are also described, observations also described, but our patient, when we gave up all the options to the patient, that observation, then we can also go for diagnostic biopsy or FNAC and then oral radiation. The patient actually chose melanoma because she was traumatic, she was just mentally traumatized by the name of a cancer. Okay, so she did not want any she did not want to take any second chance, and that's why she chose enucleation. So in these cases, whenever you do an enucleation, histopathological examination saves your day, and that's why it is very important to have a collaboration with a very good histopathological setup who can actually provide a more accurate results. This may take around 10 to 12 days for the results to come, and there can be multiple other things involved like immunohistochemical study was done for our patients. So all those facilities should also be available with the histopathological centers. So why was it a relief? Because our patient was mentally traumatized by the name of cancer. She was just scared because she had her kids to take care of, her family to take care of. So the moment we revealed the news to her that it is not a cancer and it is a benign tumor, she had such a psychic relief that she doesn't have to live in that fear. So sometimes it is the fear that kills the patient more than the disease itself. So even though we told her that it is a tumor which is benign. We would like to conduct yearly PET scan for 1 or 2 years to see whether there are any recurrences. So that's why we are still being cautious. Now after 1 year of follow-up, she does not have any recurrence, but we would like to repeat a PET scan after 2 more years. So thank you.
Thank you. It was a very well documented case. The next speaker be ready. By the time we can have a comment or two. What if you would have done a biopsy and you would have come to know beforehand that it was a leiomyoma? Then how would you manage this case?
So if we had done a biopsy beforehand, then we could have put the patient on regular follow-up. If the size was increasing or it was causing any problems, then we could have actually gone for complete excision. Because it was a benign tumor, only cataract extraction and BCR from superior incision would have been sufficient. But here, because the patient only chose enucleation, she did not want to take any second chance of any treatments or something. We did not have that option. But yes, definitely, actually, we could not differentiate clinically much between a pigmented ciliary body tumor, melanoma, and leiomyoma. Even we were more bent towards enucleation.
Quite a bit. Can you say any take on this? But in choroidal melanomas, we generally avoid taking biopsy.
Yeah.
But it is clinically absolutely the B scan and everything goes in favor. Not in doubtful cases.
Even
Are you
B
ready
scan,
for
MRI, everything is, there was no differences, ma'am. Even the PET scan said it can be choroidal melanoma, so there was no chance that we could have.
That's fine. You were justified in doing it. That's why I said it was a good document.
Even though we feel bad after seeing the diagnosis, but
No, it's fine. Are quite impatient. They have anyway waited for long. So, okay, you ready?
Yeah.
Okay, go ahead.
Peekaboo, a histopathological surprise. What will be your probable diagnosis if a 10-year girl presents to you with a complaint of on and off lower lid swelling? Probably a case of chalazion, right? But what if a 68-year-old lady presents to you with same complaints? Maybe orbital fat prolapse, right? But if a 28-year-old lady presents to you with similar complaints, will you still treat her as innocuous inflammation with medical management? Let's find out. So, a 28-year-old female presented to us with complaints of redness, occasional lower lid swelling in left eye, and on a busy Monday OPD, my inner general ophthalmologist was just about to disperse the case with medical management, considering it as a blepharitis. But right then, my inner oculoplasty surgeon asked for an examination in Worm's view. Now here we go. We had our peekaboo moment with this cute little well-defined 12 into 30 mm firm, mobile, non-tender mass over inferior orbital rim. As a protocol, we advised patient for imaging, but it was deferred by her as she was expecting at that point of time. So we decided to follow the logical algorithm and started thinking about clinical differentials. We had wide spectrum of BDs in our mind, starting from benign lesions such as cavernous hemangioma, venolymphatic malformation, benign fibrous hematoma, neurilemoma, to the malignant masquerades such as soft tissue sarcoma in our mind. But since it was a well-defined lesion, we decided to go ahead with complete excision biopsy. After a subciliary transcutaneous incision, suborbicularis dissection was done, and to our surprise, tumor was encapsulated within multiple thin capsules, which was separated layer by layer, and cryo-assisted tumor delivery was done with bipolar radiofrequency probe. After hemostasis was achieved, layer by layer closure was done with 6-0-fluorine continuous sutures. Our struggles didn't just end here. HPE picture confused our pathologists as well, as it showed very rare pattern of nests of epithelioid cells separated by thin vascular channels. So now IHC came to rescue, which was positive for HNB45 and progesterone receptors. As markers were positive for both melanin and smooth muscle cells, tumor appeared to be of myomelanocytic cell lineage, and finally we reached to our diagnosis, which was perivascular epithelioid cell tumor, PEComa, peekaboo of a PEComa. This is a 3-month post-op picture suggestive of excellent cosmetic outcome without any residual or recurrent lesion. Only 10 such cases have been reported so far, out of which 8 were seen in orbit and only 2 cases were seen intraocular. The term picoma was first described in 1992 for a lung tumor. It was then in 2005, that is 13 years later, described in the orbit for the very first time. Diagnosis is usually on basis of histopathology and immunohistochemistry. Clinical findings and radiological characteristics remain ancillary. With only a handful cases of orbital picoma in the literature, there are no clear guidelines for the management available with us. While excision followed by close follow-up is necessary in benign cases of picoma, additional chemotherapy might be required in malignant cases. These are my references.
Thank you very much, Ruju, as well as all the speakers, and I really thank the members of the next session for having that patience waiting. Thank you all.